Hi, this is Dr. Reynaldo ROJoson, Director of the ROJoson PEP Talk. I have a patient empowerment program in which I like to empower the lay people or patients to take control in the management of their health. There are 3 courses in the PEP Talk. I completed the core course on October 9, 2021. From October 23, 2021 onwards, I have been tackling health disorder and health issue courses. This may take 3 years or longer. My pep talk today is entitled Fundamentals and Generalities in Medical Management of Thyroid Cancer, Part 2. This is part of the cancer course. The empowerment objective is for the lay people to have an understanding of the fundamentals and generalities in the medical management of thyroid cancer. So part 2 will include the following topics: treatment for thyroid cancer, surveillance of thyroid cancer, prognosis, and palliative and hospice care for thyroid cancer patients. Some definition of terms in the title and delimitation of coverage of my talk. Fundamentals to mean simplest and essential facts and theories which can serve as a basis or foundation and support for advanced information. The word generalities to mean general statements of information, not covering specifics and details. Medical management to mean diagnosis and treatment of thyroid cancer by physicians. Let's start with the first topic, treatment for thyroid cancer. After formulating the pre-treatment diagnosis, including the extent of the thyroid cancer, the first thing to do before considering and comparing the options of treatment methods or modalities is to spell out the specific objective or goal of the treatment, which could either be curative or palliative. Palliative goal means relieving symptoms if all the reasonable curative approaches has been exhausted, whereas curative goal means eradicating known tumors and cancers entirely, preventing the recurrence or spread of the primary cancer. At the time of treatment, a patient may present in a cancer stage in which the goal is, at best, palliative only, relieving symptoms. These are usually the patients with advanced cancer. So the advanced cancers are usually the anaplastic carcinomas of the thyroid gland and also the advanced papillary, follicular, and medullary cancers. So these are the 4 more common types of thyroid cancers. Okay. So the goal in treatment for advanced cancer is usually palliative. The objective of treatment thus is primarily dependent on the stage of the cancer at the time of treatment. Another example, okay. This one, papillary cancer, advanced. Okay, so the goal of treatment is palliative. And then this particular patient presenting with an early stage thyroid cancer, also in the presence of neck node, which is still removable or operable. So the goal here will be curative. Stage and staging of cancers. Stage and staging describe the extent of a cancer. There are so many ways of staging the cancers. One can just classify it into early stage and advanced stage. Some would say localized, regional, and distant. Some would say localized, early, locally advanced, late locally advanced, and metastasized. Okay. And then the last one is the TNM staging, which is quite popular, which describes the size of the cancer and how far it has grown. Okay. TNM stands for the following: T, tumors, meaning how large is the primary tumor, and the nodes. Has the tumor spread to the lymph nodes? If so, where and how many? M stands for metastasis. Has the cancer spread to other parts of the body? If so, where and how much? The TNM staging for thyroid cancers is based on the following: types of thyroid cancer, whether it's papillary, follicular, anaplastic, or medullary. Age of the patients, this is for just for papillary and follicular cancers, and also based on historical track records of the different thyroid cancers. To repeat, the more common types of thyroid cancers are the papillary, follicular, anaplastic, and medullary. The TNM staging for 4 groups of patients with thyroid cancers are the following. So take note that the TNM staging is not uniform for all thyroid cancers. Okay, so it all depends on the age of the patient and also on the type. Okay, so the first group will be the papillary and follicular thyroid cancers younger than 55 years old. So there's a specific staging system for this group of patients. Papillary and follicular thyroid cancers 55 years old and older, medullary thyroid cancer, anaplastic thyroid cancers. So in the anaplastic thyroid cancer, only stage 4 is present. There's no stage 1, 2, and 3. For papillary, those more than 55 years old, and for follicular and for medullary, they have stage 1, 2, 3, 4 categorization. And for papillary carcinoma, as well as follicular, less than 55 years old, only stage 1 and stage 2. For anaplastic carcinoma, as mentioned, there's only one stage, stage 4. So all anaplastic carcinomas are classified as stage 4. Regardless of the size of the tumor, even if it's only 1 centimeter or 2 centimeters, depending on, regardless of the location, regardless of whether there is metastasis. Younger people have a low likelihood of dying from differentiated, when you say differentiated cancers, these are the papillary and follicular thyroid cancer. The TNM staging groupings for these cancers take this fact into account. That's why all people younger than 55 years old with these cancers are stage 1 if they don't have any distant spread, and stage 2 if they have distant spread. Okay, so there's a difference in the staging between those papillary and follicular cancers in patients who are younger than 55 years old and those 55 and older. Okay, so again, less than 55 for differentiated thyroid cancer, which means papillary and thyroid cancers, you only have stage 1 and stage 2. Okay, in stage 2, you have the distant metastasis, but still stage 2. Now, T here, T1 stands for 2 centimeters, less than 2 centimeters, T2, 2 to 4 centimeters, T3, more than 4 centimeters. Okay, and T4, extensive tumor, bigger. Okay, and then N stands for lymph nodes, M, metastasis. So you can see here that, okay, for those aged 40 to 55 and above, usually you have stage 1 up to 4. So in this particular patient with papillary thyroid cancer, but he is more than 55 years old, so he will either fall into stage 3 or stage 4A. There are a lot of thyroid cancer treatment being advocated. These are generally classified into 2, mainstream ones and the non-mainstream ones. The mainstream ones are those accepted and being promoted by majority of physician cancer specialists. And this is also called the conventional or standard treatment with well-documented evidences of effectiveness in various degrees. Whereas the non-mainstream ones are those outside the mainstream ones, or the popular term is alternative, with health claims usually not meeting the evidence-based standards. The commonly used non-mainstream or alternative medicine treatment for cancer are the following: herbal medicine, special diet, supplements including vitamins, acupuncture, lifestyle medicine, such as healthy eating, physical activity, and other healthy behaviors without the use of medicine. The usual definition of alternative medicine is that it is a set of products, practices, and theories that are believed or perceived by their users to have the healing effects of medicine, but whose effectiveness has not been established using scientific methods. The other categorization of types of the alternative treatment will be the natural products, mind-body medicine practices. Example will be meditation. Manipulative practices. Example would be the chiropractic therapy. And then the body-based practices. Example will be the massage. At the moment, there's no data in the Philippines regarding the use of alternative medicine for thyroid cancer. But in the United States, in one report, or in two reports, 2013 and 2018, 74% to 80% are using alternative medicine in the management of thyroid cancers. Majority are using it for symptoms relief rather than for the cancer itself, 70%, and 30% are using it for cancer treatment. So again, these are examples of the types of alternative medicines that are being used in these two reports. A word of caution on alternative medicine for cancers: delaying surgery, radiation, chemotherapy, and other traditional treatment by using an alternative medicine can allow the cancer to grow and spread to other parts of the body. And evidence shows that people who use alternative therapies in place of standard cancer treatments have a higher death rates. So in this particular study, after a median of 5 years, patients with breast and colorectal cancers were nearly 5 times as likely to die if they had used an alternative therapy as their initial treatment than if they have received the conventional therapy. So here, there's no studies on thyroid cancers, but mostly they have the same outcome. Let's now go to the mainstream modalities of treatment for thyroid cancer. Currently, these are the following: surgery or operation, cutting, hormonal therapy, hormonal manipulation, radiotherapy, and radioactive iodine therapy using radiation and then burning the cancer cells, chemotherapy using drugs to kill the cancer cells, immunotherapy, immune system manipulations, targeted therapy, gene manipulations. The mainstream modalities of treatment for thyroid cancer can be classified into two: localized therapy and systemic therapy. Localized therapy means that those are directed to a specific limited area such as the thyroid and the neck. So they include surgery and radiotherapy. Systemic therapies are those that spread throughout the body to treat the thyroid cancer cells wherever they may be. So they include radioactive iodine therapy, chemotherapy, hormonal therapy, targeted drugs, and immunotherapy. Thyroid cancer treatment may be single or combined modalities depending on the extent and the track records of effectiveness. So they can be localized therapy only, systemic therapy only, or combination of localized and systemic therapy. Thyroid cancer treatment may be single or combined modalities depending on the extent and track records of the effectiveness as mentioned. So one can use the localized therapy only, surgery or radiotherapy. systemic therapy only, okay, radioactive iodine, hormonal therapy, and chemotherapy. And one can also use a combination of localized and systemic therapy. Any cancer treatment can be used as the primary treatment, but the most common primary cancer treatment for thyroid cancer is still surgery, especially those in the operable stage. Other combinations of treatment are done depending on the anatomic stage, a prognostic stage, and other factors like track records of effectiveness. The general guidelines for the treatment of thyroid cancer. So for operable thyroid cancer, usually surgery is the main modality of treatment, primary treatment modality. Okay, it consists of thyroidectomy, which can be total or subtotal, and then a neck dissection can be added if there are evidences of neck node metastases. The other type of treatment that can be done for operable thyroid cancers are the hormonal therapy, levothyroxine specifically. It can be used as a replacement as well as for suppressive therapy. And then the other method of treatment will be the use of radioactive iodine therapy. So surgery, as mentioned, okay, could be subtotal or total. Okay, so this illustrates a thyroid lobectomy in which one of the lobe is just removed. Okay, usually there are two lobes, right and left lobe. Okay, so if one lobe is removed, now it's called thyroid lobectomy. Subtotal thyroidectomy, let's say one half of the other side and the whole lobe were removed, okay, but not all. So this is called subtotal thyroidectomy. If all the thyroid gland is removed, then it is called total thyroidectomy. Now, if there are neck nodes, then neck dissection is done. So additional treatment after the operation, let's say after the operation, what can be done in addition to the surgery? So one can give hormonal therapy, usually in the form of levothyroxine. And the uses of the levothyroxine can be twofold. It can be used as a replacement, especially in those with total or near total thyroidectomy and those ablated by RAI therapy, in which case the patient is already hypothyroid. That's why a replacement therapy is needed. Or it can also be used for suppressive therapy to prevent recurrence of the thyroid cancer. Another additional treatment after the operation that can be done, okay, radioactive iodine therapy. It can be used to ablate the remaining thyroid tissue and thyroid cancer, and it can be used to run after metastatic thyroid cancers. For the inoperable thyroid cancers, those which are very, very far advanced, in which you cannot operate anymore, so the goal will be just for palliation, one can use radiation therapy, hormonal therapy for this purpose. So the physician gives or lists the various options of treatment and gives the data on the BRCA, benefit, risk, cost, availability. And with the data given, the patient is asked what he or she prefers. So this is an example of a BRCA comparative analysis of treatment procedures. Options 1, 2, 3. Okay, on the first column, benefit, the goal of the treatment. Based on the goal, option 1 has the greatest survival rate compared to the other two. The least survival rate is with the option 3. Okay, option 2 has in between 1 and 2. Okay, and then if the risks the risks are all acceptable, and then these are the comparative prices, and then assuming that all are available, 1, 2, 3 options are available, which one will be the best option for this patient? Okay, the best option will be greatest survival rate, so option 1. Okay. Now another scenario Okay, survival rate is the same as option 2 for option 1. And then, but option 3 has the least survival rate. More complications for option 1, less complication for option 2, least complication for option 3. So the best choice here is option 2 because the survival rate is the same as, okay, option 1, and it has lesser complications. Okay. Another scenario, okay, lowest recurrence rate for option 1, but there's a high risk for complications, 5 times. Okay, and then for option 2, the recurrence rate is between 1 and 3, okay, with 3 having the highest recurrence rate. But for option 3, the risk is only 1 plus. Okay. So which do you think will be the best option to consider? Well, the best option here will be option 2. The recurrence rate is in between 1 and 3, okay, and the risk is acceptable, okay, or at just 2 plus compared to the 5 plus. Okay. Surveillance of thyroid cancer. Surveillance after thyroid cancer will be just means the monitoring for recurrence after all the evident cancers have been removed or eradicated after a curative treatment. It can also mean monitoring for progression or regression after palliative treatment when all the evident cancers are not and cannot be eradicated totally. The questions and issues involved here in the surveillance is by whom, how long, how often, and what methods. Okay, let's start with by whom. Whom you prefer, okay, can be done by oncologists or family physicians, but whom you prefer, okay, using this as the basis, competence, okay, expertise, professionalism, holistic and compassionate care, cost, availability, and convenience, and other factors. Okay. So the oncologists can either be surgical oncologists, okay. Here, when we talk about thyroid cancer, you have the head and neck surgeons, general surgeons, and ENT surgeons. Okay. Then you have the medical oncologist or endocrinologists who also treat thyroid cancer, nuclear medicine specialists, those who give radioactive iodine therapy, radiation oncologists, those who give external radiation therapy to cancer patients. Okay. So one may choose one or more as indicated and as preferred, again, using these parameters for the choice. How long will be the surveillance? For those with curative treatment goal, it's a lifetime as all cancers have the potential to recur even after a long period of time, even after 10 to 15 years or even 20 years. For those with palliative treatment goal, the duration of monitoring will be until the signs of progression or regression occur. Okay. Then at which time another round of decision has to be made, or until a call or decision for hospice care is made, meaning no more aggressive anti-cancer treatment, or until the end of life. Okay. The monitoring can be up to the end of life. Okay. There are two situations in the monitoring in terms of how often. When you want to monitor for immediate results of the treatment, and you want to monitor the recurrence of cancer after curative treatment. So monitoring for the results of treatment, usually you monitor for the side effects and complications of the treatment and the response of treatment, usually those treatments which will take some time, like hormonal therapy, radioactive iodine therapy, chemotherapy, and radiotherapy. Okay. So the duration of the monitoring will be depending on the types of and duration of the treatment, recuperation time, expected response, such as 2 to 3 months for hormonal therapy, RAI, radiation, and chemo, etc. And the frequency will range from daily, especially for operation, to every month, okay, and or average of 6 months. In monitoring patients for recurrence of cancer after curative treatment, okay, how often? It depends on the type of the cancer. Okay, treatment done, usual prognosis, time of treatment, is it soon after or long after, and then the mindset and personality of the patients. The general guidelines will be this one. More often for those with higher risk for recurrence, such as aggressive type of the cancer, early post-treatment, such as say 1 to 2 years when recurrence usually occurs, and anxious patients who need frequent psychological support from physicians. As to what methods of monitoring, there are two methods: symptom sign directed surveillance approach and the regular screening instrumental laboratory diagnostic test directed surveillance approach. For the first one, symptom sign directed surveillance approach, this just means the patient's symptoms and physician sign findings will direct the instrumental laboratory diagnostic test to be done. For the regular screening instrumental laboratory diagnostic test directed surveillance approach, here what is being used is a battery of screening tests on the possible site of recurrence, okay, even in the absence of signs and symptoms. And the usual tests being ordered in this battery of tests are the ultrasound of the neck and total body radioactive scan and PET scan. So the physician gives the list of options for surveillance and then gives the data on the BRCA. With the data given, the patient asks what she prefers. And then so the comparison will be several. So early detection will be one of the parameters for comparison. Then the survival is another parameter for comparison, and then the last one will be the quality of life. Okay, so you list down the options for the whether it's symptom directed or battery of test directed, and then you compare the benefit in terms of early detection, risk, cost, availability. Then you also compare them in terms of survival, okay, risk, cost, availability, and then lastly you also compare them in terms of quality of life, and with the additional data on risk, cost, availability. So this is an example of the comparison of the two options: symptom directed, battery of test directed. Example, if for early detection, so you have 3+ for option 3, so better than option 1, just 1+. But in terms of survival, they have the same survival whether you use the symptom directed or battery of tests. Now, in terms of quality of life, for option 1, symptom directed, it's better. Then option 2 will be poorer. So you balance the everything here. So usually, plus the cost here is the battery of tests will be the most expensive, and then you have a problem with false positive rates, okay, in the battery of tests. So usually the most cost-effective choice here will be the symptom-directed approach. Prognosis of cancer, thyroid cancer. Prognosis means you just estimate how the cancer will go for a particular patient, meaning the likely course of the cancer without treatment, if with treatment, whether curative or palliative, the likely outcome, what are the chances of recovery from cancer, what are the chances of response to treatment, what are the chances of response to cure, okay, in terms of remission or recurrence. And then you can also do this in terms of estimating the 5 to 10-year survival rate or median survival rate. The prognosis will be dependent on the type of cancer, stage of the cancer, inherent biologic behavior of the cancer. Some are fast-growing, some are slow-growing, with or without comorbidities of the patients, okay, and the gravity of the comorbidities is another factor that will influence the prognosis, and the track records of the cancer itself. When you talk about track records, it's based on studies on the 5 to 10-year survival rate and the median survival of the different types of cancer, either by stage of the cancer, 1, 2, 3, 4, and with or without treatment. So these are the data that you use to determine the prognosis of a thyroid cancer. The 5 to 10-year survival rate of cancer just means the percentage of patients who are alive 5 to 10 years after they were diagnosed or started on treatment. So this table shows the 5-year survival rate of the different types of thyroid cancer. So you can see that for stage 1 and stage 2, okay, so for papillary, you have near 100%, near 100%, near 100% for these 3 types of cancer. And then for stage 2, you have near 100%, near 100%, but 98% for medullary carcinoma. Okay, just using stage 1, stage 2, you can say that these two has a better prognosis than medullary cancer. Okay, then when you are in the stage 3 already, the 5-year survival rate drops down from 100% to 93%, and then to 51% when you have stage 4 already. Okay. So the same is true here, decreasing percentage, okay, decreasing percentage by stage, okay. So anaplastic carcinoma has the worst prognosis, okay. So it's all stage 4, it only has 7% 5-year survival rate, okay. So as mentioned, papillary cancers has the best prognosis compared to the other 3, and then anaplastic carcinomas have the worst prognosis. So the other parameter that we use to determine the prognosis based on the track records will be the median survival of cancers. This just means the length of time from either the date of the diagnosis or the start of the treatment of the cancer that 1/2 of the patients diagnosed with the disease are still alive. Okay. So usually it's in terms of months, okay, when you talk about overall median survival. Okay, but some would go for years, okay, especially those with a good prognosis. Okay, so median, then you determine the data, whether it's in terms of with treatment or without treatment, and then the median survival also based on the stage and based on the type of metastasis. So since thyroid cancers generally have good prognosis, especially papillary and follicular cancer, the median survival data are often not mentioned. They just mention 5 to 10 years survival. Okay. And as I said, median survival are usually in months, and these are usually important in patients with far advanced and incurable diseases. So in summary, for the prognosis, 5-year survival rate for thyroid cancers, papillary close to 100% for localized, around 80% for metastasized, follicular close to 100% for localized, around 63% for metastasized, medullary close to 100% for localized and around 40% for metastasized, anaplastic carcinoma close to 31% for localized and 4% for metastasized. Palliative and hospice care for thyroid cancer patients. There are 2 terms that one will encounter in the medical management of cancer patients, which most Filipino lay people are not familiar with, and which most Filipino physicians do not acquaint the patient with. So these are palliative care and hospice care. Palliative and hospice cares are being used in patients with advanced cancer, patients who have little or no prospect of cure and who are expected to die, and for whom the primary goal is to optimize the quality of their remaining life on Earth. So both palliative and hospice provide comfort for advanced cancer, both in terms of spiritual and mental and physical comfort. Palliative care can begin at the diagnosis at the same time as the treatment, and it may consist of anti-cancer treatment, whereas hospice care begins after treatment of the cancer is stopped. When there is a decision, no more anti-cancer treatment, when it is clear that the person is not going to survive the cancer. So the process will be like this, the flow. You have advanced cancers, then palliative goal of treatment is instituted, okay, or the goal the goal of the treatment is just palliation, and then so palliative care is being given. So once there's a declaration that there's no good chance the patient will survive the cancer, the care can be transformed, can be shifted to hospice care. No more active anti-cancer treatment, just supportive care. So summary takeaway in this pep talk for part 2, I have discussed treatment, surveillance, prognosis, palliative, and hospice care for thyroid cancer patients. Takeaway in relation to patient empowerment, be always in touch with reliable medical information on fundamentals and generalities in the medical management of thyroid cancer. Knowledge is power. It gives power. Use the 4 Ks of patient empowerment, kaalaman, kakayanan, karapatan, at kapangyarihan to gain greater control over decisions in the medical management of thyroid cancers. So with that, I end my pep talk. Fundamentals and Generalities in Medical Management of Thyroid Cancer Part 2. I hope I have empowered you to have a better understanding of the fundamentals and generalities in the medical management of thyroid cancer. With that, I close my lecture and thank you for your kind attention. Mabuhay kayong lahat.